established some outreach clinics. So we have established clinics in Oxford, where I go twice a year, Southampton, where also I go twice a year, and Norwich, where my colleague Dr. Herger goes twice a year. And I'm going to talk a little bit about what I think we're providing as added value for that. Because of our large team, it can be overwhelming for the families to be sat in a room surrounded by health professionals. So we now have a dedicated area where we have our own waiting facility, we have our own playroom, and we also have access to 2 rooms, and we felt that was very important, and split up with issues. So we've got therapists perhaps in one room and the doctor and nurse in another room. What we also have is a combined clinic. We do with an orthopaedic surgeon 4 times a year, so every 3 months, children that we think may need surgery get reviewed in that clinic. And what we are due to start shortly is a combined clinic with a spinal surgeon. Because, as you know, some individuals will develop scoliosis and may require spinal surgery. And we were, prior to the start of this spinal clinic, we're having to send any children who may need scoliosis surgery to Sheffield, which is obviously quite a trek. What we also do is have an adolescent clinic, which we hold in conjunction with an adult physician. So we're very lucky in Birmingham. We've got Dr. Neil Gittos, who works at the University Hospital, and we hold a clinic with him twice a year where we see individuals between the ages of 16 to 18. In terms of bisphosphonate treatment, we deliver that through our day case unit, so we don't have overnight stays anymore. We used to admit children to hospital to stay overnight, but the majority of our patients are on zoledronate, which is a single infusion rather than 2 or 3 day infusion, which we give every 6 months to those of them over the age of 5. Between the ages of 2 and 5, we give it every 4 months, and we only are actually using pamidronate now for those under the age of 2 years. And we've got a 2-day schedule every 3 months for those individuals. What we've also developed is where our therapists will deliver intensive therapy sessions, where we will invite children to come to Birmingham. They may be local to Birmingham, in which case they just come from home, or they may come from further afield, where we get them to come and stay in a local hotel for 2-3 nights, and then they'll come and see the therapists and the specialist nurses and maybe the doctors over those 3 days. And I'm going to talk about how that is helping. In terms of what our therapists also do is provide quite a lot of community visits to schools, to homes, to other areas. We have an ongoing research study where we're looking at the use of a vibrating platform to try and stimulate muscle strength and bone strength, and we're also using that vibrating platform routinely in some individuals who we feel need rehabilitation. So I'm going to mention now and talk about a few areas which I think are important. One of which is diagnosis. Right? And you've all been through this, all of you who have osteogenesis imperfecta or have a child with osteogenesis imperfecta, you know what an important time that is. You'll also know that sometimes it can be straightforward. So, for example, if there is a known family history, so if you're an individual patient, a parent has got osteogenesis imperfecta and they're aware of the risk, and perhaps a child is identified antenatally as having abnormalities on the bones on the antenatal scan, or they present or the child is born and they have perhaps typical features of OI such as Bruce Spira, hypermobile joints, etc. But in many cases it can be much more difficult and it can be delayed. And this is much more of an issue in children who are mildly affected, so more the sort of OI type 1 or the OI type 4 individuals. And as you're probably aware, some of these families go through child protection investigations because obviously if a child presents to hospital with an unexplained fracture, the immediate default pathway is this non-accidental injury. I'm aware in my own clinic of some families who've had quite a hard time in that situation before the diagnosis of OI is made. And I think that's where the input of clinicians or doctors who are familiar with osteogenesis imperfecta is really quite important, because although this is not a rare condition, it's a condition that is not that familiar to most doctors, lots of nurses, and I think that's where specialist services can provide that advantage and can spot clinical features that others perhaps haven't identified. And what can sometimes happen, and certainly happened in our experience, is that sometimes you may identify, so a child presents with an unexplained fracture, there's no apparent family history, but then when they come to our clinic and you start to go through the history, you actually work out that, yes, there is a family history. So perhaps grandmother's got osteoporosis, or the parent has had a few fractures in childhood, or another scenario which I had a few years ago where a child presented with an unexplained fracture and there was no apparent family history, started to go through the family history, and the mother had quite a lot of problems with her teeth, had required lots of dental work at a young age, as had her sister, and it became apparent that this was probably osteogenesis imperfecta in the family. So I think that's where specialised services and individuals familiar with the condition can provide that added value of diagnosis. Diagnosis of eye is predominantly clinical, so looking for family history, looking for clinical features, but supported by X-rays, typical features on X-rays, bone densitometry, and on some occasions by genetic investigations, but we don't routinely do genetic testing because, as I say, the diagnosis is very much clinical. And sometimes making a diagnosis can be very important for a family. So we've had a family in our clinic relatively recently. I can't remember the age of the girl. She was probably about 4 or 5 years of age, where we'd perhaps seen her once or twice and there was a suspicion, was this osteogenesis imperfecta, was this not? And they came to clinic and they said, you know, other family members are saying, just treat her normally, there's nothing wrong with her. And they were feeling very anxious because on the one hand there's the doctor saying, well, this could be OI, and the family saying, no, it's not. And I looked at this girl and I felt she definitely had OI, and I said to the parents, your daughter has osteogenesis imperfecta. And that was a huge relief to that family being given a definitive diagnosis rather than being put in the sort of nowhere land of the uncertainty. So I think diagnosis is a very important time, and I think what also goes along with that is provision of information about the condition. So clearly, again, you'll have gone through this experience, and I think, again, it's very important to see families, and even though they may have previously been given verbal and written information about osteogenesis imperfecta, it's very useful if experienced teams can see the families. So this week, on Thursday, I went over to a local hospital about half an hour away with a specialist nurse and a physiotherapist, where a baby who is now 9 months old had been admitted with a fractured femur some 2 weeks previously. She was on gallows traction. Diagnosis of likely osteogenesis imperfecta had been made on X-ray appearance. We were hoping the family were going to get transferred to our hospital, but because she was still on gallows traction, that wasn't possible. And I recognised the importance of going over to see that family, to see those parents, to talk to them about the diagnosis and to give them information. So they have been given information about osteogenesis imperfecta. They've got one of the Brittle Bone Society general information sheets which goes through type 1, type 2, type 3 and type 4 OI. But what they weren't clear about is, well, what type is our daughter? Is she severely affected? Is she mild? Is she moderate? And by going over there and seeing them and talking to them, I was able to explain that their child was most likely moderately affected. It's likely that she was going to walk independently. She was probably unlikely to require long-term wheelchair assistance. She would be in mainstream school, and lots of issues that I was able to answer. So I think that's very important, the accurate provision of information. And the other area where we find information is very important in times of diagnosis is information to schools. So you may have say a child with type 1 OI, maybe 5 years of age, 5 or 6 years of age, who has a fracture or two and then is getting identified as having OI, And it's very important at that time to engage the schools and to provide them with information to try and allay their fears and provide reassurance and advice regarding appropriate supervision of the child. We've had examples of one child who was relatively recently diagnosed who was kept off school for a long time following the diagnosis because the school were just so nervous about having a child who may break their bones easily. And we've also had issues, as you may have experienced, where a child with OI may have a fracture, and there's some reluctance from the schools to actually get them back into the school. They may be in a cast, they may be in a wheelchair, and some sort of reluctance of the school, and we've had to work with the schools to overcome that. As I said earlier, we have developed outreach clinics, and although these clinics we go to are run by doctors who are very familiar with osteogenesis imperfecta, very familiar with bisphosphonate treatment, what they don't have that we can provide is the extended multidisciplinary team familiar with the condition. And I think what we have is the ability to try and move things forward for an individual child and their family. So, to give you an example, we saw a lad in one of our outreach clinics who was in his early teens, he was about 13 years of age, who was becoming less mobile, was becoming very wheelchair dependent, where we felt that we could improve his mobility. And we invited him and one of his parents up to Birmingham for one of our intensive therapy sessions, and we spent 3 days in Birmingham. And we were able to build his confidence, we were able to build his independence to start mobilising again with the use of crutches. And our therapist actually took him shopping, and he loved that, and it was just fantastic that he could gain that confidence. Another example of where I think we provide some added value is another of our outreach clinics, where only this year we saw a lad who's about 10, 11 years of age, whose mother is also affected with osteogenesis imperfecta, and this lad has sustained recurrent fractures of his femurs from the age of 1 year to the age of 10 years. So he spent lots of time in hospital, lots of times immobile, and his mother had a lot of anxieties about and lots of fears about the diagnosis of OI and its management. She'd had experience whereby a relative had had surgery to insert an intramedullary rod, where there'd been a complication of that surgery and there'd been lots of problems. And so she was very nervous about the idea of perhaps having surgery to straighten the bowing deformity in her son's femurs. And I have her permission to just sort of recount. She gave me some feedback following our last visit, and she gave me her permission to give you some feedback about potentially what impact we had. So we invited him and his mother up to Birmingham for, again, a 3-day session earlier this year. And what she said is, before our visit to BCH, the upstairs 3 bedrooms of our house were never used by the family, as her son had a real trip of fear of tripping in the shower room and also going upstairs. So all 3 of them, so herself and her other son, slept downstairs in the living room. She then said they came to Birmingham, and what she found very good was everyone had experience in dealing with OI and could relate to exactly what her son was going through. And it was the first time they'd met people who really knew his condition in terms of what it meant to his day-to-day life. She described it as a completely life-changing experience, and she recognised that although there is no cure to his condition, and because of his condition he has a disability, there are many ways in which he can be enabled. And she was shown how by backing off a bit, she could let him gain independence, and he could do a lot more for himself. So now, he actually gets upstairs, he has his own bedroom, he has his own things, they can go shopping, they can go to the cinema, and she says, I get to sleep in my own bed instead of on the corner on the floor, in the corner on the floor. So she's very grateful. She said, God bless you and your team, whose ever excellent idea was to build this group of experts. And that's really what the National Commission funding has provided, is this ability to have the staff to go and clearly develop this service. I'm going to stop talking in a minute. I'll just touch on a couple of other things. So, one of the things I think we recognise in our service is that sometimes we need to challenge as well as support. So obviously we're providing support to the families, but we need to also challenge a little bit and sort of try and move things forward. So clearly what we're trying to do is to try to get the children to become more independent, to take more responsibility, to have knowledge about their condition. These are individuals that in 5 or 10 years' time, maybe going to college, maybe going to university, want to start living independently. And that is sometimes difficult for some families. So some families find that difficult, where we're trying to encourage that independence. And they find that difficult. Clearly they've had a child who were diagnosed with osteogenesis imperfecta perhaps several years ago, and they've maybe been a bit protective of their child. And sometimes they can find our suggestions and interventions difficult to accept, and sometimes we can have a bit of a hostile response where we try to suggest things. So one example I can think of relatively recently is where we've got a child with type 3 osteogenesis imperfecta who's about 5-6 years of age, who currently uses a Panthera wheelchair, where we've suggested that actually maybe she'd become a bit more independent if she started to use an electric wheelchair. And that's been difficult for that family to sort of accept. And that's just sort of an example of where, as I say, we not only we should support, but we need to sort of occasionally challenge. Until, as I said at the beginning, what we also have access to in our team is a psychologist, Julia, who should have been here today, and a social worker. And I think until you get these individuals as part of your team, you don't really realise what they can provide. Prior to getting a psychologist, you think, well, do we need a psychologist? And actually, when you have them in the team, you recognise, yes, you do, and there's a huge amount that they can do. So there may be some things that are maybe not directly related to osteogenesis imperfecta that they can help with. So they may be also help around the time of diagnosis, or they may be able to help with, say, targeted interventions. So we had one child where there was issues to do with toileting, trying to get this child independently toileting, and she worked with a psychologist and managed to achieve that. We had another teenage child who, for many years, had been dependent on one crutch to get around, and yet we felt she didn't really need that crutch. It was more sort of a psychological crutch rather than a true functional crutch. And with the psychologist, she managed to get her to give it up. And our social workers, again, is incredibly helpful, so we can provide advice about benefits, access to other services, and it's been extremely helpful. And one of the things we are trying to develop in our service is the concept of transition. So we recognise that these individuals are going to go on to adult care. We usually move them on to adult care around about the age of 18 years, sometimes a little bit later depending on the individual. And although we have a dedicated clinic, an adolescent clinic, where we see individuals between the ages of 16 and 18 with the adult physician, the process of transition is a much longer process, and it's something that really should be taking place once an individual starts going to secondary school, but they need to start understanding their condition, need to start to become more independent. And so we're working on that process. I'm not saying we've solved it, but that's something we're trying to work with, particularly with one of our occupational therapists.